Good morning, everybody. So, this is the answer to the quiz on the 1st of May. So, this was a 34-year-old female who presented with a 1.5 year history of a slowly progressive indurated plaque on the left cheek. I was quite surprised because there was marked induration, and this is a very sort of well defined pigmented lesion with irregular borders. In normal circumstances, I would have thought BCC. That is what I thought, but it's a young girl, Indian girl, and there's no reason to suspect a BC, and she had no other predisposing factors. And surprisingly, she also had a lymph node on the right side of the neck, which she's had for the last few months, she said, and has been also complaining of intermittent pyrexia. So I was a bit puzzled. I didn't quite know what was going on. Anyway, so here's the histological picture. I've uploaded two low power images, and you can see even on low power that the epidermis is slightly atrophic. You can see that the reti ridges are attenuated. This is called attenuation of the reti ridges, where the reti ridges have lost their sort of normal undulation. You can see here, and they've become flatter. Even at this power, you can make out the melanin incontinence here, the dilated capillary loops, and you can make out that this is a superficial and deep perivascular and perifollicular infiltrate. Okay, so when you're seeing even on low power, you're seeing this epidermal atrophy, you're seeing this pigment incontinence, and you're seeing a superficial and deep perivascular and perifollicular infiltrate. The first thing that would come into your mind is lupus. Okay, so that is one of the most commonest differentials for a perifollicular and perivascular lymphocytic infiltrate. And you can see that the hair follicle is scarred here, it's destroyed, so it's been eaten away. There is dermal scarring. Now, this is not papillary dermal sclerosis. Sclerosis is much more homogeneous. This is just dermal scarring, and you can see this in any interface dermatitis in the later phases. And this lesion is about 1.5 years old, and hence you can also see a hint of vacuolar interface change, though this is not prominent at all. But the simple fact that there's attenuation of reti ridges, melanin incontinence, and there is upper dermal scarring is still indicative of an interface dermatitis. And you should be able to make the diagnosis even though you may not actually be seeing a lot of inflammation along the interface. Okay, there is basket weave hyperkeratosis. It's not there's no parakeratosis, just basket weave type orthokeratosis. The epidermis now is in the post-inflammatory phase. The inflammation is much deeper, and hence the induration. You're seeing the inflammation quite deep down, and because of the dermal scarring, I think clinically we were able to palpate the plaque. Okay, you can see here that the erectoris pylori muscle is destroyed. You can see here it's no longer attaching itself to the hair follicle, it's destroyed here. This is the erectoris pylori muscle again. Okay, and you can see a perifollicular lymphocytic infiltrate here. On higher power, again the basket weave orthokeratosis is highlighted. You don't really see basement membrane thickening, though it looks like the epidermis has been marked with a pencil. It's just very well defined basement membrane, but it is not quite thickened. And these sort of vacuolated cells may be, it may be suggestive some amount of residual interface change, but sometimes it can be difficult to differentiate these vacuolated cells from melanocytes, but there are too many of them. Normally there should be one melanocyte for every 8 keratinocytes. Here there are too many, and I think some of these are residual vacuolated epidermal keratinocytes. And I've just highlighted the perifollicular infiltrate here. So yes, epidermal atrophy is present. There's no spongiosis. There is basket weave orthokeratosis, no parakeratosis. There is interface dermatitis. There is melanin incontinence, but no hemosiderin. This is not ochronosis. There is follicular destruction, scarring, and papillary dermal scarring, but no papillodermal sclerosis. I've discussed this before. Papillary dermal sclerosis, when we're mentioning this, it's much more homogeneous and is indicative of lichen sclerosis. Why I said this is not lichen sclerosis is because the papillary dermis is not homogeneous. It's not homogeneously sclerosed. You can still see the collagen fibers in between. If you look back to the lichen sclerosis cases I posted earlier, it can be a bit tricky, but if you look at cases repeatedly, in lichen sclerosis as well, you see all the changes that you're seeing here, but you don't see the deep infiltrate usually. You see the dilated capillary loops, which are present in lichen sclerosis. But often at this phase, what you do see is a band-like lymphocytic infiltrate underpinning the sclerosis when it is present. Here it is more papillodermal scarring, post-inflammatory in an interface dermatitis that is often seen. But it is a difficult case. You can see here, this is not papillary dermal sclerosis. This is just scarring that is present here. You can make out in this higher power picture. So the distribution of infiltrate is superficial and deep, perivascular and perifollicular. There are no granulomata, there are dilated capillary loops, and there is no vasculitis. I've given you quite a few differentials to pick from, and the answer here is discoid lupus. It's not granuloma faciale. It is not a tubercular direction. There are no granuloma at all. Granuloma faciale is vasculitis, much more severe inflammatory infiltrate, no interface change usually. In fact, there is a Gren zone usually described. It is not a tattoo granuloma. It is not a fixed drug eruption. Fixed drug eruption can have all these changes in a post-inflammatory phase, but then you don't see a perifollicular infiltrate that is deep, and it doesn't last this long either. Lichen sclerosis is a close differential, and I did personally think about this when I was reporting it, but again, I discussed the features against the diagnosis. Morphea, usually much more deeper infiltrate, and usually, interface change is not that prominent, though it can be present. Morphea can often overlap with lichen sclerosis. Having said that, there is no collagen bundle thickening, which you associate with morphea in this case. Atrophic lichen planus, again, yes, possible in the post-inflammatory phase, but then you don't see the deeper infiltrate as you're seeing in this case. All right. I hope you enjoyed the quiz. So thank you very much.